Hi everybody, welcome Sunday night to I Was Supposed to Have a Baby. We are really, this is the 42nd episode and I'm super excited to bring on Dr. Chavi Karkowsky, who is the author of just an absolutely incredible book called High Risk Pregnancy, and she's going to tell you lots more about it while she's here. But she's really a fascinating individual in that she has, she's a high-risk OB, she's a maternal fetal medicine doctor, and in addition to that, not only can she really give a really wonderful insight into what it's like to be a physician and how to really treat all of you and when to know when all of you should be seeing high-risk doctors, at what point in your pregnancies, or at what point even before you get pregnant, should you be seeing these doctors. But she also has had a wealth of experience of really, just multiple years of, being in the trenches, of doing so many different deliveries, having thousands and thousands of patients. And I'm really just looking forward to getting her on here and having her talk about her experiences and really just giving you a window into what it's like to be a physician in this kind of world, in this kind of space. So I'm just waiting for her to join. Let me just see if I can grab her because it seems like she's not coming on right now. Give me a second, guys. 1 second. Let me see if I can grab her. Let's see if I can find her. Let's see. Hopefully she should be here. Okay, I'm hoping she should be here. Otherwise, we're going to have tech difficulties again, and it's going to be so exciting. I want to hear from all of you about what, the kinds of things that you'd like to hear from her. And I could, go on and on forever. She's still not coming. Tech difficulties. Oh no. All right, let me try to grab her one more time, see if she's going to show up. And then otherwise we'll stop and start again because she might be having difficulty on her end. So let's see. 1 second. Okay, guys, hold on. Okay, I'm hoping she's going to come now. Let's see. I'm hoping. Otherwise, we'll just get me to talk, and that would not be good. Although I could probably give you a little bit of an insight, but she's really the expert. Anybody have any questions? Anybody want to wave? Anybody want anything while I'm waiting for her to come? One of the things that we're also super excited about is the Fertility Summit that's coming up. It's coming up next month. It's the first ever virtual Fertility Summit where representatives from all of the different Jewish fertility organizations in the United States, let's see if I can get them all. There are 10 or 11 of them. So it's Jewish Fertility Foundation, A Time, Bonei Olam, Pua, Nechama Comfort. Ooh, I just saw her join. Okay, so that means she's here. So that means that she will be coming on in a second and you won't have to listen to me talk anymore. Hi, Chavi. So just click to join. Here we go. And she's here. Okay, guys. See? I talk by myself anymore. Anyway, there are 11 different organizations and they're all coming together for this beautiful event next month. I was just trying to fill the time as I was waiting for you to come. So I'm so glad that you're here.
I apologize. I'm good at lots of things, but Instagram is not one of them.
It's all good. You know what? Sometimes I'm good at Instagram, and frankly, even myself, there are times that, just welcome to technology. It is 2021, so I can't blame it on 2020 anymore, but it is what it is. Anyway, Dr. Karkowsky, it's really an honor and a pleasure to have you here. Please, we have lots that we want to do tonight, but please, I've already introduced you to the audience, but please, in my stories and in the feed, but please tell everyone who you are tonight.
So hi everybody, I'm Chavi. I'm also known as Dr. Karkowsky. My staff calls me Dr. K. I answer to almost anything. In my day job, I am a high-risk pregnancy doctor, and we can talk a little bit more about what that means because I think a lot of people don't know, and why you might need one. In my other day job, I write. So I write a lot for the lay press, for normal people, not doctors, about pregnancy, but also about high-risk pregnancy, which often is something that either is often where I take care of women undergoing loss, infertility, medical conditions that make it hard to get pregnant. So a real confluence of care with people who work in the primary infertility field, like my reproductive endocrinology colleagues. In my spare time, I write for places like The Atlantic, Slate, The Washington Post, and my first book just came out. It's not just anymore, I guess. It's been almost a
It's not
year.
just, it's
I
amazing.
know, it's almost its birthday. It's been a
No,
10,
show it again to the screen so everyone can see it.
so
Yep.
it's called High Risk: Stories of Pregnancy, Birth, and the Unexpected. It's a cute little book. I'm proud of it.
It's not a, I was going to say it's not so tiny. It's not a large tome, but oh, I lost you. Oh, you're back. Okay, good. It's not a large tome, but it's not so small. And it's really, I want to talk about the book, but I want to, before we sort of get into the book, I'd love it if you could share with people a little bit more about the kinds of work that you do and why someone might come find you and why they might need a physician like you in their lives.
Sure. So I think I have the most interesting job in the world, and I say this to medical students all the time. Um, I am an OBGYN. I trained in OBGYN. I was an OBGYN generalist doctor for a couple of years, and then I did 3 more years of training, what we call a fellowship in high risk OB. And that fellowship covers a bunch of stuff. It covers fetal medicine. So all that fetal ultrasound diagnosis, that's something that somebody like me does. When you get an ultrasound in an ultrasound unit, usually someone like me is overseeing it and making sure the technicians are getting the right views and coming to talk about what those views mean. And then also there's the fact that I deal with all the maternal complications, right? And those can be things that are maternal medical conditions, which maybe some people knew they've had since childhood, have always known that if they were to plan a pregnancy, they'd want somebody like me involved. So asthma, diabetes, thyroid disease, history of cancer, you name it, we take care of it in the time surrounding the planning of a pregnancy, the experiencing of a pregnancy, and post-pregnancy. And then there are the conditions that relate to the pregnancy itself, things that you only get in pregnancy, like preterm labor, preeclampsia, and other diseases like that. So one of the things I say a lot is that women's health is human health and human health is women's health, because I think a lot of people, especially before they try to get pregnant or are pregnant, have this really limited view of what pregnancy care needs to be. But anything that happens to women is going to happen to women who are going to plan on being pregnant or be pregnant.
Right.
So a lot of what I've done in the last 9 months is taking care of, for example, a lot of women with COVID pneumonia who are pregnant. And that's important to think about, right? Because when we don't plan to take care of these women, then our ICUs are not set up for them. And it's my job not only to take care of them, but to advocate for them within the hospital system so that we don't end up with a patient in the ICU who I can't properly care of because I need a fetal monitor, for example.
Right.
And so that's our role, both inpatient and outpatient.
And so, what would, if someone knows that they have a specific medical condition, let's call it asthma, at what point is that person coming to you? I mean, it sounds like clearly that person might be coming to you after they know they're pregnant, but is there, and you mentioned about that there might be a role for that person to come to you before they're pregnant. So, why would somebody do that? Why would that be necessary?
It is always our favorite thing to see somebody before a pregnancy. I think a lot of people don't even know we exist. So in some part, what I'm trying to do is raise awareness. We're out here. We love to take care of you, and we're going to do a great job. Anytime you're on any medications, anytime you're on any sort of regimen, anytime we just need to understand how pregnancy would interact with a disease, that's the person who needs to come see someone like me. And we love to see people before the pregnancy. Why? because before the pregnancy is when we can look at all your meds and make sure that they're safe to be pregnant on. It's when we can look at your disease state and actually plan, is this the right time for you? If we wait 6 months, can we get you into a place that's going to put you at less risk for pregnancy loss, less risk for miscarriage, less risk for preterm labor? And would that 6 months be worth it to you? And I think that there are very few other sort of training sets that can get you to that really level of really complicated decision making and with a patient to really get you the healthiest possible pregnancy. And because I work with pregnancy, anything that happens to a pregnant woman, I always know a little bit about, right? So you'll never be my first patient with lupus. You'll never be my first patient with 7 pregnancy losses. One of the things that's, I think we're kind of proud of, it's hard to scare us. We take care of a lot of women with really high risk conditions. I can't always promise you that everything's going to be okay. I say in my book, everything is almost always okay, and my work is done in the almost, which it turns out is a pretty wide and deep space. What I can tell you is that you probably aren't the first person to go through this, and that it's probably not the first time I've done it with somebody. And I think that that can be tremendously comforting when you're
Tremendously comforting.
Your pregnancy.
Yes, I look, I mean, I can even say from my own personal experiences that, you know, I had many second trimester losses. And when I was with maternal fetal medicine doctors like yourself, high risk doctors, for them to say to me, this is not the first time I've seen this. Like, while that was upsetting because obviously it meant that so many other people were also suffering, it was also very reassuring, saying like, okay, at least I know that I'm in a place where some of this, it may not be understood yet, but at least everybody's trying and will be supportive. So yeah.
I think it comes to another thing, which is a common sort of goal between you and me, the way we tell stories and try to build community, which is that until you hear that, you often think it's just you, right? You're the only one. And there are many, many horrible things about going through pregnancy loss or preterm labor. But one of the loneliest is thinking that you're the only one this has ever happened to. And people think that not because they're dumb, people think that because we don't talk about this stuff, right?
Right.
And it's really, really hard to find a corner of the world where it's discussed.
Right. I'm curious, how did you always know you wanted to go into OBGYN? Did you always know that you wanted to do MFM? Like, what was sort of the path personally for you?
So it's so funny because I didn't even think I wanted to be a doctor. And then when I was a doctor, I actually started 3rd year of medical school. And I write about this in the introduction. I thought I was going to be like a pediatrician or a child psychiatrist. I thought I was going to be somebody who really like wrote in a notebook and lived a quiet life. And then I did general surgery and I was like, shoot, I seem to be an adrenaline junkie. I did not know this about myself. I had never done anything adrenaline related before, you know? And then when I did OBGYN, I just loved how they were surgeons, you know, we operate,
Right.
but they really, the love for their patients was just really manifest. And I also really felt like it was this amazing sort of ability to be a priest or a rabbi as well. Like there's very few other parts of the hospital where you are somebody's medical experience and their life cycle experience. And I do think, and this is part of what I write about and why I write, is that I think so much of what I'm in the room for, some of the most sort of wonderful and also terrible, but also most interesting stories in the world. I sort of can't understand why we don't tell them. They're amazing. And the ability to be in that room, to be invited into that room, is really a privilege that I wanted to sort of continue to do. I couldn't say goodbye.
Amazing. Amazing. I know we have a lot to cover today, but I wanted to hear a little bit more. And I think for the audience too, like just take us sort of through the trajectory of your career, of like the different paths and the different places you've practiced, and sort of, because I know the book really encompasses so many of the different stories that you've had over the course of your career. So how did you get to the different spots and the different places?
Well, I went to college at Yale. Oh, I spent a couple of years in Israel before that, and then sort of during college. I was really not sure what I wanted to do with my life. I thought I was going to get maybe a doctorate in Talmud. It was a confusing time. I think as for us.
I was going to say for many people then.
I made the decision to go to medical school, which was, I think, a very good call, actually. I seemed to be in exactly the right place. The thing I want to be very honest about is how wandering a path it was. I applied to medical school. I did medical school. And then this part I think is kind of terrible. As many of you might know, to apply for residencies, to decide what kind of doctor you're going to be, there's a match. So you apply, you interview, and then you submit a list. And then when match day comes, you open an envelope. And a computer has taken the list from the programs and a list from you and put it together. And you open that envelope, and wherever that envelope says, you are contractually obligated to go. And I wasn't sure if I wanted to be an internal medicine doctor. I thought I would go into critical care. There's that adrenaline, but still procedures, right?
Right.
Or if I wanted to be an OBGYN. And so I applied and interviewed for internal medicine and OBGYN residencies, and I listed them both on my list like a lunatic. Don't do this. This is not a I remember my dean saw me on match day and was like, Javi, I saw what you were doing. I thought nobody knew. She was like, and I just figured you knew what you were doing and I left you alone. I was like, why would you leave me alone? I clearly had no idea what I was doing.
So funny because my roommate in medical school was also going through the same sort of like path where she like, for her it was either family practice or OBGYN. But by the time she needed to submit her list, she had picked one. So she hadn't ranked both.
Normal. I mentioned this just because I do think it's such a part of our identity as physicians. Like, the neurosurgeons have a different sort of vibe than the nephrologist. But yeah, it all started from the same place. And I think the search for identity is sort of manifest in this very funny, very structured process of applying for residency. And I guess my point is there's more than one way to get here from there. Because in the end, I became an OBGYN and I really was missing some of the like really meaty medical problems. And so I went into MFM, and arguably it's exactly where I started out, which is the intersection of medicine and OBGYN. Right. So now, of course, it makes sense. But at the time, I think it was not great. I ended up matching to my first choice program, and I did my OBGYN residency at Harvard. And then I became an OBGYN doctor. I thought that I was done with training. And I was an OBGYN doctor, and I had my first child after actually a lot of trouble conceiving, which was a very painful time for me. And sometime in the middle of that, I just realized how much I missed sort of being somebody who never sent patients away. I was used to being at a big hospital where if a patient had a problem, we would have a solution or we would have to figure it out because there was nowhere more advanced than us to go. Do you know what I mean? And I realized I had a fellowship. So I came to New York for my fellowship. I had 3 more kids around that time, in and around and after fellowship. And now I'm an attending. For most of the time that I've worked, I usually have worked in hospitals that are serve as safety nets, which usually means that more than something like 75% of their population is on public insurance. For the last 10 years, I've worked largely in a community of women of color, immigrants, and some of the poorest zip codes in New York City and honestly in the United States. And I love it. So that's the population I work with here in America. Amazing. I do want to insert this little sort of detour that we've talked about, which is that my family moved to Tel Aviv for 2 years, from 2017 to 2019. Where I thought I was going to work in Tel Aviv or South Tel Aviv with immigrants, sort of the work I did in America. And because of bureaucracy and maybe because of destiny, I ended up working in a Haredi hospital in the north of Israel, which I loved, which I didn't expect to love, and in which I felt loved. I felt like they really just loved having me. So at some point, if we ever want to talk about my time in a Haredi hospital and sort of what I learned there, that is also experiences I love to talk about.
Okay, that's we need to schedule that next live now. We'll do that next time. But today, look, I really wanted to have you discuss all of that to sort of set up this next topic of ours, because your life experience and your professional experience very much, has given you the tools and the experience, life experience, and this experience has given you the experience, not the way I wanted to start that sentence or complete that sentence, but it's the wealth of your experience has brought so many different kinds of patients and different kinds of situations into your life. And I think it's informed so many of the pieces that you've been able to accomplish in medicine. And so, I mean, what we wanted to talk about today is sort of this this concept of advocacy in terms of patient advocacy and also advocacy coming from the physician side towards the patient of how to merge those two pieces together, and then to make sure that everybody feels like they have a piece of a story of a patient situation that's going on. So please, I mean, I'm not the expert here. I need to pass this along to you before I mumble my words even more.
So one of the things that I think sort of became a point as I was writing my book, I don't think I knew it before I wrote the book, was just how much of medicine is about telling a story, and about how much of successful medicine is for a doctor to maybe help guide a patient towards a story that they can live with, that they have to live with far past the experience they're in. And then I think on the doctor side, I think what people don't realize is how much we're invested in creating and telling a narrative to each other, which is often a really constructed, boring narrative, but is a story nonetheless. So if it's okay, I'll share with you guys an excerpt from my book. Would that be okay?
Please, please. It's you and I talked about this, and I think that this excerpt is going to be a beautiful way to really set this up and have people understand a little bit more about what you're trying to get at.
So we talked a little bit about this excerpt. I just want to warn some of you, it does touch on sort of second trimester loss, which I know is really, really hard to hear about. I would argue that it's important to talk about, and that's why I have. So this is a story.
And yes, yes, and very much. And also, it's important to talk about in this space. Like, this is a space that we talk about the difficulties that one has trying to build their family. And we talk very openly about pregnancy loss, about infant loss, about stillbirth. So this is exactly the right place to do it. So please.
It's from my chapter about periviable birth, and the chapter is titled Unnecessary Story. Some of us are calling it a baby. Some of us are calling it a fetus. Some of us are calling it, though we catch ourselves when we do. None of us feel good about any of this. We're all talking to Annie Riley, but really to her whole family. She's pregnant, 23 weeks and 0 days by our best estimates. Until yesterday, she was having a normal, uncomplicated pregnancy. Then yesterday, while she was running errands, her water broke. She came to see us, and while being evaluated, she became uncomfortable. Now she's in labor. We are trying to stop the labor, this complicated process by which our body works to eject the contents of the uterus. Our treatments for this situation are old and they're not terribly effective, and right now it looks very much like Annie will be delivering within the next few hours or days. So we're in her room talking and talking about the pregnancy, about the fetus, about the baby. Is it a baby or is it a fetus? That's the thing, really, the crux of the matter, because we need her to tell us. Here is her limited menu of options. Option A is the story of a miscarriage. In this story, the pregnancy is a fetus that is less than 24 weeks. The rate of survival at this gestational age is very low. Those infants that have survived are overwhelmingly affected by the sequelae of their extreme prematurity, including blindness, lung problems, and cerebral palsy. The chance of getting a child out of this process is small. The chance of getting a healthy child is vanishingly small. If she chooses this story of miscarriage, we will allow the fetus to be born. We will not torture it with tubes and sharp stings. We will offer comfort care and make sure it is warm and place it on Annie's chest for as long as it stays in the world with us. Option B is the story of an extremely preterm birth, and it's not a miscarriage. In story B, the pregnancy is a baby. A baby will be born, and we will fight for its life. We will place tubes and lines in its tiny translucent body. We will bring to bear all the wisdom and knowledge, all the science and computers, everything we have. It likely won't be enough. The baby might still die. The baby will probably still die. If it lives, it will be impaired, probably somewhere between moderately and severely so. Annie has to pick a story. We are all very insistent that she has to pick a story as soon as possible. Why? Because if it's story B, we will start to do things to her, and some of those things are not very nice. We will give her strong medications to try to offer the baby some narrow advantage when it's born. We will strap her to the bed and vigilantly monitor the heart rate of the baby. We will swarm in and out of the room, touch her and examine her and poke her for blood tests. We will consider offering her an emergent cesarean delivery, with all the risks entailed by major abdominal surgery. The kind of cesarean delivery we would offer her, by virtue of the anatomy available to us at 23 weeks, would be a vertical uterine incision which will compromise all her future pregnancies and deliveries. We will do that even though the chance of this baby leaving the operating room, not the hospital, the operating room, is less than 30%. For story A, we won't do any of that. We will not even listen to the fetal heart rate because we wouldn't do anything differently. We don't do major abdominal surgery and risk a woman's health if it's not going to change the outcome. We will make the room quiet and peaceful. We will try to make sure she has one stable provider and a nurse who knows her and who is good at this kind of situation. We hang a picture of a leaf with a teardrop on the door so that all the members of the staff know that a loss is occurring in this room. When the delivery happens, we give the family time. We help them take pictures and start a memory box. We will mourn. Until Annie makes her choice, her providers are so very uncomfortable. Because what is good care in story A is malpractice in story B, and vice versa. How can we care for this patient until she tells us what care is?
Yeah, I've read your book, and even, but just hearing you say it out loud again now, it brings back all of those swirling emotions, both for me personally and my own losses, my own second trimester losses, which were not pre-viable. They were 16 or 17 weeks, but also for me as a physician and attending those deliveries and having not been as a pediatrician, not as a maternal fetal medicine doctor, but having been brought in after the story has already been decided upon. And then either I'm pronouncing a baby dead or I'm whisking the baby off to the neonatal intensive care unit. So I'm there at the end of the story. You're there at the beginning of the story.
Well, what I would say is that neither of us is there at the end of the story, right?
Right.
I think I've come to sort of, as I've done this for longer and as I've matured, is understand that part of my job, the agenda for the doctors is to get a story that we need to know what to do today. I need to know what to do in the next 10 minutes, next hour. And what I've come to realize is that part of what I'm there to do is actually help the patient decide what story she can live with for the day and the month and the year, and honestly for the rest of her life, right? And for some people, that story needs to be, we did everything we could, which is hard because that's the most dangerous phrase in medicine, right? Because we did everything we could. But there's a lot we can do, and not all of it is good.
Right.
And then there's people who can feel really more comfortable, and I say this is a process that started, and we're just letting it happen. And who you are and who your family is and which of those stories is sort of livable for you is far beyond anything I can decide. But it's my job to sort of hand you those and say, what can you live with? But also they have real concrete physical differences in your care. This story is very powerful. So when you need to decide it for forever, but you also kind of need to decide it for now.
And how do you guide a patient like that? How do you, I mean, obviously you lay those choices out for them, but then when someone sits and says, I just don't know what to do, I just don't know what to do, I can't see myself with a handicapped child if that child makes it, but I don't know how I can live with myself if we don't do everything. Like what happens then?
Well, like for example, what you just said is somebody who really is having trouble anticipating a handicapped child. And I would say to her, we could also say that this is a process that started and that we can let it finish. And there's nothing wrong in that. And there's nothing unloving about that, right? Sometimes that's the most loving thing you could do is take the time that you have and have it be comfortable and have it be together. That might be a narrative that's more helpful for her to hear. I want to be clear, these are all true, right? This is the thing about stories, that multiple stories can be true. I would never lie to a patient. And then the other thing I say a lot, I find myself saying a lot is, when I have a right answer, I will tell you that there's a right answer. Like if you need antibiotics, I will tell you, you need antibiotics. You can say no, it's your body, but I will tell you there's a right answer and a wrong answer. The reason we're having this long conversation is because there is no right answer. All the answers I have for you are terrible. Okay, so let's just start with the fact that we are in a terrible place, because I think it's helpful to contextualize like that. You are not going to be in the story you thought you were in. that story is not here and I'm so sorry. Given that your menu is so limited, right? Given that it's going to be traumatic, let's start from there. And also that if I had a right answer, I would give it to you, I promise.
And how do you put together the notion that there are patients that are going to make decisions that are different than what you would make with all of your knowledge at that time? Like how
Sorry, I don't even know what I would have made. You know, I actually came in with one of my pregnancies at 23 weeks. And almost everybody who works in this business is very much like, you know, I've seen it go down. I don't want a periviable baby. And I wanted steroids. I was surprised. I was like, no, I want it all. I want it all. I may be delusional. I may be completely like just not dealing with what's happening. And in the end, I did go to 37 weeks and they're 10 years old and everything is fine. But I didn't know that then. So I don't know that I think that there's this humility of like, I have no idea what I would want. If there's a right answer, I'll give it to you, right? But these are all, I have only wrong answers for you, which I think is hard for a doctor, right? That's not exactly our job all the time.
right.
But when it is my job, I think it's really important to say that that's your job. I think there are people for whom they'd rather somebody come in and jolly them to like, everything's going to be fine, but that's not true. And
Right.
that's not the doctor I've ever been.
Right. Do you think that like have there ever been situations where you very much or some of your staff felt differently about the choices that patients were making, and how do you grapple with that amongst staff when you're, faced with this kind of a situation?
I think the thing that happens a lot actually is, I mean, it happens all the time that people don't listen to us or don't make the decisions we want them to make. Or even when I say there's a right answer, for example, a lot of women come in with their water broken at 16 or 17 weeks, and the prognosis at that point is very, very poor. And the danger is very real, not just for the pregnancy, but for the woman herself.
Right.
Women get infected. There have been maternal deaths. There have been hysterectomies because of this. And the odds of getting a healthy child out of it are very, very small, even smaller than periviable birth, because even if they get to 23, 24 weeks, living without that amniotic fluid is just damaging in a lot of ways. And I have a lot of patients who just are like, yeah, I'm just going to keep going. That's just how it is. Um, that's their right, right? It's their body.
Yep.
It's their baby.
Right.
It might be a fetus, but it's their baby, right?
Right.
Um, and it's my job to support them safely as much as we can. And I have a lot of patients like this actually, and it's scary, right? It's scary for me to take care of them. Um, I think one of the things I write about in my book is this idea of against medical advice, that people choose to do things against medical advice. And that if somebody decided, like, for example, I have a patient in the book who broke her water and is continuing the pregnancy, and we recommend you do that in the hospital because things can change quickly. And she ultimately ends up having to go home because she has two other kids and her husband gets fired and they're going to lose their house if he can't go back to work. And I think a long time ago, against medical advice would mean like you sign the form and you go off and you fall into a black hole and that's it, right?
Right.
You refused my best care. I only give one kind of care. It's the best. There's
Right.
no other options. There's no plan B or C or D. There's just plan A because that's how medicine is, right? You do it the right
Right.
way, you don't do it. And then she would be gone. But there's something really arrogant about that, right? Like, you do it my way or the highway. Like,
Yep.
I think we've gotten to a better place where I have those patients all the time. And I'm like, you know what? Your life is really complicated. I only know what's best in this part of your life. And you know what's best for your whole life. So let's talk about what to do. And for me as a doctor, sometimes it means I send somebody home on oral antibiotics who really should be on IV antibiotics. But she can't stay to get the IV antibiotics. So I'm also left with sort of all bad options as a doctor. And
Right.
I think for a long time you were like, I don't want to give her the wrong antibiotics. There's some ego in that, right? I know the right answer. I know it would be the answer on a test. We're all A plus students. That's why
Yep.
we did it. And sometimes you have to be like, I'm going to do the B minus answer, right?
Right.
Because it's still better than the F answer.
Yep.
A new place, I think, of humility in the care relationship that we have to come to, or we lose more than we gain.
And how do you personally manage, I mean, and I, speaking as someone who deals with lots of different high risk situations all the time, right? You see high risk deliveries, you see death, you see the things that none of us see. How do you handle that from your side, from the physician side, from the medical team side? How does one handle dealing with trauma on a daily basis?
It's a really hard question. I'm not sure that I have like the right answer. I don't think I,
Again, no
yeah.
right answers, no wrong answers, right?
I talk in the book a lot about how like it's not my tragedy, right? Like you have to be really aware when you do this work that it's not your tragedy, that you're not the main character in this story, but you're adjacent to the tragedy, and then being adjacent to it again and again and again is a very particular perspective, right? It's a little bit buffered, but it's so repetitive. And the people I know who do this work do end up with a little bit of distance. And we all have our ways to manage. One thing that's really important is that we are all completely convinced that we do the most important thing in the world. It's very satisfying to feel like you've helped people at the really edges of human experience, right?
Right.
That you can guide them in whatever small way, physically, medically, even sometimes spiritually, through something that is really hard. Um, but I would also say that many of us come home exhausted. Um, I do sometimes feel like maybe I would be more present for my children if I wasn't so emotionally drained from work. I will tell you that when we moved to Israel for the first 8 months, I couldn't work, which was a nice little test case. And it turns out that that was terrible. That was way worse. It's way better for me to be working. And then the other thing I do, yeah, it was terrible. Validated all my life choices. I mean, the other thing I do is I write, right? I feel like when I write, I don't want it to just be therapy. It's really important to me that my writing is meaningful to people, not just me sort of getting rid of stuff. But I do feel like the writing helps me take something and maybe make sense of it. And if I've done it right, it helps me make sense of it in a way that's bigger than just one story or one person or even just me. It makes sense of it in a like, let me put this in American culture for you, or let me sort of place this in the American medical system for you. And I think that for me is actually tremendously satisfying. It really helps heal.
Do you did you ever get a sense your from your family that like that it was too much, like that they felt like it's enough, like like obviously you clearly need the work, and I know I clearly need the work. I think we all go into this feeling like we have this place and this need to give back and this need to sort of take our brains and to use it in a purposeful way and to do that in a very beautiful, purposeful way. But do you have you ever felt yourself, or have your family ever said like, do a little bit less? It's not, don't push yourself so much.
Um, that is not the partner that I have. The partner that I have is very beautiful. For example, he's putting children to bed right now so that I could do this talk with you. Um, I feel very lucky. I definitely feel like my kids might have a different feeling in 15 or 20 years, and I worry a lot about that. But my partner will always say, they need you, go. Or even when I'm talking about writing, which I have always treated more as a hobby, he'll say, no, you need to go do this. I'll put the kids to bed. So I'm just very lucky.
Yeah, no, it's just it's an interesting construct. I mean, as caregivers, as women, as caregivers, and I hear this a lot from different women who are doulas, women who are OBGYNs, women who work in this space in general, where we're our work is seeped with lots of emotion and lots of stories and lots of trauma and lots of pieces. We know we're needed, but how we take care of ourselves, where the outlet is, where the balance is, how we give to our patients, how we give to our families. Like, look, this person here was also just writing. She says she thinks that her family feels the weight of what she does. Like, I hear that a lot.
The one thing I will say is that my second chapter is called Scut is Love. So I don't know if people know what scut is.
Explain.
Scut is the medical slang term for like all of the work in medicine that has nothing to do with medicine, but without which nothing will happen. So it's all the forms you have to fill out and the disability and calling the pharmacy to make sure they got the prescription and I don't know, talking to the OR to make sure your case can go. And it's actually 90, maybe 95% of what we do, right? Like
Yep.
there's 3% of knowing which antibiotic is the right antibiotic. And then it's like 97% making sure they've got the right size IV and that the paperwork is filled out and the pharmacy got the order and that the nurse knows, and that's all scut, right? Which sounds so profane, but it doesn't mean anything dirty. And my chapter is called Scut is Love, right? Which actually I think a mom would understand more than anybody, right? Because it's all that. It's
Oh, we
changing
do. Yes.
the laundry is both like total drudgery, right? But the total act of getting it done for somebody who needs it, that's love. And that's what it is. And in that chapter, I talk a little bit about how sort of I really need to be warm and fuzzy. I kind of need my patients to love me and me to love them. And I always thought that was good. And I came to understand that actually sometimes it wasn't, because sometimes I get a little burned out. And when I do, it sort of just falls off of me. Like all that compassion, all that empathy, I can hear it hit the ground. I can hear it crack on the tile. And then what do I have left, right? And I have a friend, she actually is an abortion provider. And I've asked her, like, sometimes it's hard work. It's hard. She deals with patients in like the hardest situations, some of who I'm like, do you ever resent them if they made a bad choice and they put you in this situation? And she said to me, this is like my new motto in the end of the chapter. She said to me, I don't know their life. Looks hard from here, but I don't know their life. And that, in the chapter, I called that compassionate distance, right? Where she was like, it's not my job to judge. It's not my job to decide whether or not I agree. They are an adult. They need something, and I will provide it. And in some ways, that's like more true and more solid than the warmth that I was sometimes bringing. That like just firm professionalism. And I think sometimes that's the way to a long career of true sort of compassion is she's unbreakable, right? She's unbreakable because she doesn't need you to be nice.
Yep.
And I thought that was really beautiful. And actually, so now I don't know her life. In some ways, it sounds so rude, right? But actually, it gets you there. It's not my job.
No, it very much does. I think that that's a really just a very beautiful way of kind of encompassing the kind of work where we're here to do a service. We're here to provide people with what they need at this point in their life, but this is a very small microcosm of what their life is, and it's to make judgments about the 99%, the rest of the 99%, is really is not appropriate. Yeah, it's
again. It's just an idea of like I am filling this very small role for her and nothing more, and that's all I should fill.
Right.
And I thought that was just really sort of beautiful in its plain-spokenness, and I really took it with me.
Yeah, and I think it really comes back to exactly the point that you were making before about these pre-viable births, that these families are making decisions that they have to live with for the rest of their lives, not only in this 24-hour period or 12-hour period or whatever it is where you're seeing them and that decision needs to be made. It's something that will reverberate with them for their lives. And so you're giving them options, but you don't know what the rest of their life looks like. And I think it's a very powerful way to think about it. Yeah.
But I think the other thing that I think is really helpful to know about this for people who are not medical providers is to understand the urgency that the physician sometimes has or the provider team sometimes has, where we're so insistent that you make a choice or that you pick a context. And I want people to understand that that's what medicine is. And medicine is all about storytelling. I have another excerpt I'm happy to read that we've talked about.
Yeah.
Because I think it's a really important thing to understand that the way doctors talk to each other is all about constructing a story that must cohere. And if it doesn't, we get in trouble with each other and we get in trouble with ourselves. And that's when we start to get stuck on things.
Yeah, I think, yeah, I know where you're going with this. We have about another 10, 15 minutes. I think this is a beautiful way to kind of bring it all together, and it'll really help for the listener to help them understand more of what the physicians go through in this kind of scenario.
and how we get stuck too. We get stuck and you can get us unstuck. I guess what I'm trying to say is I think once you understand how much construction of a narrative has real, meaningful, concrete effects on your care, it might be a helpful way to navigate a system. So this is the story of Nora, in which nothing bad happens, I sometimes say, because in so much of my book I can't say that. Nothing bad happens to Nora. Okay, so this is the story of Nora, which is in the same chapter. Nora Salmon had one prenatal care visit with our hospital, just this week, at 35 weeks pregnant. She did have a first trimester labs. They were done somewhere else. From her purse, she produced a wadded up purple pregnancy passport that had a negative HIV test scribbled on her 12-week visit. But then she had a second HIV test done just last week on her first visit to our hospital. This is our protocol for patients in their third trimester, and Nora's third trimester HIV test was positive. Third trimester HIV is a risk for her, but also a risk for her baby. The baby can get the virus during labor and delivery and live with it its whole life. Or we, her care team, could prevent that right now. The initial HIV test at the time we took care of Nora was a tricky one. It was known to be falsely positive a large portion of the time. Back then, this false positive report was frequent enough that it didn't generate a full result, because it was only partial. What it did generate was a reflex test called a Western blot, a more precise protein assay, to tell us whether the result was real or not. I think I'm dating myself with this story. You can tell.
All good.
When Nora came into labor and delivery, her Western blot was still pending, currently in process on the countertop of some anonymous lab. For right now, there was the positive partial HIV test in our hands and a woman in labor in front of us. If Nora truly had uncontrolled new onset HIV, our doctors could have offered her a cesarean to minimize transmission to the baby. But they've got that crumpled purple paper and her very clear protestation that she has not had any new sexual partners since then and that her partner has not either. Nora is 100% sure she doesn't have HIV. No, she is 1,000% sure. The overnight team doesn't recommend a cesarean. Major surgery based on a probable false positive seems extreme. But they do want to do something relatively low risk, something that can offer the baby protection from lifelong HIV. They start antiviral medications during labor. Antiviral medications like zidovudine can prevent transmission to the neonate during labor and delivery. The plan is to stop the meds if Nora's result returns negative. That was the plan. Morning comes, Nora is still pregnant. I join the team on the labor and delivery floor rounding on the high-risk patients. I check the computer. The Western blot has a result. It is, as we have all hoped, negative. Negative, I sing out. That's wonderful. But then I look closer. That result's been back since 3 in the morning. Why is she still on the zidovudine? The team hems and haws. We were busy. We wanted to make sure. We wanted to talk it over, And I do know, once you have a label, it's very hard to let go of it. Once you have a story, it's very difficult to change to another narrative. Even if that story is false, even if you can point to digits on the computer screen that say this story is not true. Still, the absence of action, the not treating of this patient, came too hard for a team that entered with one reality and exited with another, just wanting to do the right thing and not sure enough to know what the right thing was. The patient was already exposed to the risks of the medication, right? So it's another dose or two until we make sure that everyone agrees that this is the new truth. Let's turn off the zidovudine, I say. Everyone laughs, but nobody moves. In the end, I have to write the order myself. I ask the nurse if she wants me to push the off button on the IV pump, but she tells me that now I'm being silly. Am I say. Once upon a time, there was a woman with HIV. She came to us to have a baby. We kept that baby healthy by giving large doses of medications. We were heroes, and we won. That is a story, but is it this woman's story today? No. The story changed, but we kept rolling forward, handicapped by our medical narrative by the story we were telling. We kept our sword out, chapping at the dragon who long ago left the building, or perhaps never existed at all. If we get better at this, maybe we can figure that story out more accurately. Maybe we can figure out how to look at the dragon in the story. Are you the real enemy? Do we need to have this fight? Sorry.
Right. Yeah. I mean, it's really hard. It's really hard, as you just exemplified. It's really hard when you've been telling yourself one thing over and over and over again. It's really hard. I mean, you had multiple people on that team and nobody could make the decision overnight. They had to wait for you to put your foot down in the morning.
something just happened. One of my cousins actually got hit by a car. This is a terrible
Oh,
story.
I'm
And
so sorry.
no, terrible.
They're okay.
Everybody's fine. Nothing bad
Okay.
happens in the story either.
Okay.
This person, physician, they are very knowledgeable. Got hit by a car as a pedestrian, crawled over to the edge of the road so he wouldn't get hit again, and called 911. And when 911 came, they were like, "Oh, you got hit over there, and you're here. You must have been thrown by the car like 20 feet to the edge of the road." And my cousin was like, "No, I crawled." Right? And because this is the story the EMT wrote down, this is the story that propagated to the emergency room. This defined all the imaging. Do you know what I mean? Like he was
Right.
in the face of this story. And I think this happens to a lot of us.
Yep. 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 I think that, yeah, it's, right. What I think it happens as patients also, where we tell ourselves that we need to have a certain medication or we need to have a certain procedure or else, or else we're not going to be able to move forward, or else that treatment won't be successful. Like I hear this a lot in the fertility space specifically, where people get fixated on needing to have some kind of treatment, some kind of drug, some kind of intervention, or else things won't go well, because that's the narrative they've told themselves. They've heard other people have had it, and they can't sort of see their way out of it, even when physicians tell them, no, you don't need that based on your medical history. They can't go there. Yeah.
Yeah, and it's really hard. We get stuck. We have such a desire for a certain story, a story where you're the hero, or a story where you found the treasure. I found the treasure. It was the IVIG. It's what I needed the whole time.
Yes.
And maybe you're right, but maybe you're not. And when you're stuck in that story, it can be really hard to hear other narratives that might be other ways out. I don't mean that I think the stories are important. I think they're often the thing we need. But until you get to the end of that chapter, you don't actually know which way it's going to go, which makes it
Right.
really
Right.
but I also think you can tell the story, right? As a patient, you can tell the story, and the way you tell that story will change the treatment you are offered.
Absolutely, absolutely. It's any, and this goes for any kind of medical situation. It's about, we as physicians are listening when you tell your story, and the way you tell it, and the kinds of words that you use, and the pieces that you choose to share with us. Because obviously, when telling a story, if you're coming in and talking about a story that's happened to you over the last 20 years, you're not going to take 20 years to tell it to us. So you've already chosen your narrative, and the way you choose that will really sort of dictate what our care is to you. So absolutely, absolutely. Um, Look, Dr. Karkowsky, I'm incredibly grateful to you for sharing all of these different pieces to us, to give us a window into how you, as the care providers, think about all of the way these patients are treated, these stories, these pieces. It's we often don't get a window into this part of the story. It's really important for patients to hear how much we are invested. I think I'm using we. There are too many pronouns here that I'm kind of interplaying here, because I'm playing the patient and the physician sort of all at the same time. But I think that it's unusual to get this piece, and I'm incredibly grateful that you've been able to share so much of this with us.
For people who enjoy this perspective, the book, I'm going to show it to you one more time, is
Please
called High Risk, Stories of Pregnancy, Birth, and
lift it up a little bit more. Just lift it up. Yep. High risk. There it is.
And it's available everywhere, Amazon, Barnes and Nobles. There's an Audible book for those of you who still have long commutes and aren't the work from home pandemic workers. And I think you might enjoy this, and I always love hearing from people. You can reach out to me through Instagram, even though I've already demonstrated my ineptness at it.
All good.
But my website is chavikar.com, CHAVIKAR, and there's a contact form there, and I respond.
Yeah, and it's really actually it's a beautiful book, and you go through different chapters, and you don't need to read the book all at once. You really actually, it's very easily digestible in different chapters, and you can sort of put it down and then come back to it. So it's not very overwhelming, and it's really very emotionally it's really relevant, and for people especially in this space, it's really beautiful. It's a really beautiful window.
The other thing I'd like to say is I think often for many of the for many other people joining us, I think a lot of them times their husbands or parents might not understand what they went through or might have not have the words to explain it. I think there's often very little sort of post infertility, post loss, post anything processing, especially for men, believe it or not. It's terrible for women, but it's also in this funny way terrible for men. And sometimes I think this might be a way to start those conversations or people give people a context for what they went through. A lot of times people are very unclear, even decades later. Anyway, I hope it does help. If anybody reads the book, please do let me know what you think.
Absolutely. Okay, everybody, you know how to reach Dr. Karkowski, and I'm so grateful for your being here. Thank you so, so much.
Thank you so much.
Okay, good night, everybody. Take care. Bye.